Welcome to the Enlace Health Masterclass. The conversation continues today with the next segment of why healthcare isn't working and how to fix healthcare at its core. Enlace Health CEO Bill Nordmark will open our session with a 10-minute overview that addresses key issues at the center of today's chaotic healthcare world. Immediately following Bill's presentation, he'll begin a lively Q&A. Before we begin, I'm going to walk through a few quick housekeeping instructions. After the initial 10-minute presentation, we will have a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is also being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access that recording. If at any time you don't see your slides moving or have trouble with the audio, try refreshing your browser. You can also submit any technical questions into the Q&A box because we're here to help. With that, I am pleased to welcome today's presenter, Bill Nordmark, President and CEO of Enlace Health. Bill, thank you for being here today. I will now turn the floor over to you.
Welcome, I'm Bill Nordmark. Here today to talk about how healthcare is unsustainable and why the current fix in healthcare is a Bandaid and how we need to change from the inside out. Healthcare is a mess for a lot of different reasons. Primarily because we have uncontrollable costs, unsustainable challenges, a pandemic the past 18 months, and a challenge where, quite frankly, healthcare is broken from the inside out. The way we pay for it and the way it's consumed, it causes challenges for patients. The cost in the data speaks for itself. The Kaiser Family Foundation would say that nationwide out-of-pocket expenses in 2021 went up 10%. They're expecting that to continue to grow at that pace, through 2026. Per Health Evolution, the Kaiser Family Foundation also did a survey of employer business groups. 96% of those business groups think healthcare costs are excessive. CMS, the Center for Medicaid and Medicare Services, talks about national healthcare expenditures expecting to grow at a rate of 5.4% through 2028 to $6.2 trillion. So on the one hand, you can see the aspects of, the data doesn't lie. The challenges are the challenges, and the costs continue to go, up and to the right. I think there's also a challenge around the fact of just us as consumers, right? So how does it work today, and what's the challenge? Well, yes, we're trying to fix a lot of things around population health and telehealth, for example, in the pandemic. And telehealth's been around forever. It's a good, valuable asset, but at the end of the day, it's still built on a fee-for-service transaction, right? So you're still paying for a volume of service and a rate for that interaction. So those types of periphery changes, haven't delivered on the promise of changing the unsustainable nature. As we all know, the industry has been chasing this path towards value-based care, moving away from a fee-for-service environment. And this dynamic has happened in other industries. Take the financial services industry and everyday commerce, for example. In 1950, the credit card industry kind of came about with the introduction of the Diners Club card. In that interaction of the Diners Club card, previously we lived in a checking cash world, i.e. fee for service in the healthcare space. It was a manual process. Everybody remembers the carbon paper with the slider or the push down carbon paper dynamic, and a manual process to introduce these credit cards. It did not become ubiquitous and sustainable until we actually had a Visa or MasterCard that created rails behind the scenes to automate all these processes. Ultimately, that's what we're here to do at Enlace. And so this analogy of moving the checking cash world to credit cards is the same that we're trying to do in healthcare with moving from fee-for-service to moving to value-based care, which today is a manual process, just like that carbon paper process that's there. It's an analogy I like to use. And this shift from fee-for-service to value-based care, living in this fee-for-service world, causes a pain point for the consumer. The analogy that I give everybody is, let's take an airplane ticket. When you purchase an airline ticket, you pay for it up front, you have your trip, land at your destination, and come home. That's not how it works in healthcare. In healthcare today, if you took the airplane ticket analogy, you would buy your ticket, you would not pay for it up front, you would land, and then you would start getting bills from all the interactions. So you get a bill from the gate agent, you get a bill from the snack, you use the restroom, you dropped your bags off, you said hello to the pilot, and at the end of the day, you get this $5,000 airport usage fee bill. You don't know what it was for, right? And so now you got to scramble and find all those bills. And so if you take the aspects of this horrible consumer experience, continuing cost increases that are unsustainable both on employers, consumers, and the industry, add in a global pandemic to exacerbate all these challenges and put pressures on hospitals, it's a pretty unsustainable process. The challenge in healthcare to meet changing this unsustainable cost and unsustainable nature of healthcare has been born out of the inertia of healthcare. We talk all the time healthcare is different, and it is. It's a multi-trillion-dollar part of the economy. It's 19% of GDP. It's an enormous area of the economy and challenge, and has a significant amount of stakeholders that all have to participate in work together to change this dynamic. At the end of the day, though, I think we can all look at ourselves in the mirror and say, we haven't made the necessary changes that we need to make to truly get the industry where it needs to go. What do I mean by that? We still live on a fee-for-service infrastructure. At the end of the day, how healthcare is consumed and paid for is still on a volume-based scenario. Even interactions that are, we say, value-based or taking risk are still 99% of them upside only or some type of population risk that, yes, might change the baseline of healthcare costs, but isn't necessarily changing the trend of healthcare costs. And so all that to say, that's kind of the inertia component. Beyond the inertia component, there's a technical component, right? We're still riding on rails of interactions and interoperability that either doesn't exist or is significantly old. And we make many changes that we feel are innovative, but they're Band-Aid approaches. And right now is the time for non-Band-Aid approaches and actually truly changing it at its core. What we will need to do to change it at its core is to rethink how healthcare is consumed and paid for. But the critical component is we have to meet organizations where they are in this journey. I've been in this industry a very long time, over 20 years, and I can tell you that where I've had my most success of working with payer, provider, patient organizations has where you bring technology to them, you meet them where they are on the adoption curve, and as you meet them on the adoption curve, you actually help them move them to the future opportunity that they make. Partnering with them from technology perspective, from business process perspective, to get the outcomes where they need to go. So whether they have a value-based program that's at scale or technology that's at scale, or they're not doing anything, you have to be able to meet them on that journey. When you look at what needs to happen in the industry, I came up with this vision that the tide needs to lift all boats. We as a healthcare industry need to come together to fix these challenges. And as we came up with the mission for our organization, we looked at truly innovating from the core, changing healthcare from the inside out. So right now I'd like to quickly introduce you to Enlace. It's our organization, Enlace Health, and our mission to change healthcare.
In the connected world of Enlace Health, we recognize that healthcare cannot continue on its current path. It's too chaotic, inefficient, and ultimately unsustainable. In order to fix healthcare, it means restructuring from the inside out, rebuilding it with better connectivity and logic to drive value. Enlace Health is doing just that, unraveling the mess and turning the chaos into an integrated and efficient ecosystem, connecting payers, providers, and patients to drive sustainable value. Whether piloting your first value-based care project or scaling your current program, you begin the Enlace process wherever it's right for your organization. With our team by your side, you are guided through the connected world of Enlace, Your solution is continuous, from design and analyze to implement and administer, delivering better quality healthcare at lower cost, all provided in one connected ecosystem. Come join our connected world of Enlace Health. Sustainable healthcare delivered.
So this is Enlace Health. We are so excited about our vision. We are so excited about bringing this mission to healthcare. We're excited for our company, but we're more excited for our customers, partners, organizations we work with. And most of all, we're excited about the industry and where the industry can partner with our brand and our organization. Why am I passionate about our mission? Beyond just being a part of the organization, the company, I too am a healthcare consumer. I have 2 young boys, I have a wonderful, beautiful bride, and we interact in the healthcare industry. As most of you know who are patients, young kids, ball players, we visit the ER or the Children's Healthcare Center pretty frequently. And as a healthcare person in the industry, it really pains me that the interactions are so bad. It's just a bad consumer experience. It's frustrating. And all of you in healthcare, I know you also get the double whammy, which is all your friends call you about healthcare, because since you're in healthcare, you have all the answers. You know what their explanation of benefits says, and you know all these challenges that you can solve for them. So you get the phone calls, help me with this bill. I too am a consumer. I too am passionate, and our team at our company is passionate about changing this industry from the inside out and making it better for all healthcare stakeholders. This movement has to happen. The movement is real. As we've discussed, the unsustainability has to move into a sustainable nature. I, as a consumer, want to live in this world that is changing and transforming healthcare. We've seen analogies of moving from checking cash to credit cards that totally transformed how we as consumers live in an environment to improve the sustainability of these capabilities. So the movement is real. The time is now. We have to move forward with this, and as all of us as consumers need to buy in on this. So why should we care? For that same reason. We have an unsustainable asset to our economy, to our population, to our country, and our industry can be at the forefront of innovation and providing healthcare benefits, right? Our employer groups, our payers, our provider organizations, our tech partners, all focused and centered around a patient, providing them value. We often talk about wanting to engage patients more. We talk about patients taking more responsibility in the healthcare system. So if it is so broken and they are unable to interact or shop for healthcare, then the consumer is challenged and will not see value from the industry. We've also seen in a global pandemic that the inability of our infrastructure and our unsustainable inefficiencies have not prepared us for something that came and snuck up on us over the past 18 to 24 months. So the time is now. The time is now for us to fix our industry from the inside out, to drive the efficiencies for patients, to drive the value in the industry for our customers, and to hit that triple aim of better healthcare at lower cost and better quality. We are passionate here at Enlace to support our payers, providers, partners, and patients, and the industry as a whole, to transform the industry from unsustainability to sustainability and driving value for everyone. Please come join us in the connected world of Enlace. Sustainable healthcare delivered.
Okay, first question. There is a lot of discussion in healthcare about innovations and changing healthcare. What makes this different?
Well, Chandler, I think that's a great question and kind of one of my favorites. Obviously, I just talked a good bit about, how kind of we see this concept of changing at its core. But there are a lot of innovations in healthcare. There's a lot of innovations around delivery. There's a lot of innovations around items like telehealth and population health and those types of different innovations that are in healthcare. But the biggest challenge is all of those innovations today still ride on fee-for-service rails. they ride on an antiquated payment model that at the end of the day limits their value. And so what makes this strategy so different is that we truly want to change healthcare at its core. We want to move away from a fee-for-service model. Will some fee-for-service always exist? Sure. But we ultimately want to move the industry to where the organizations can truly process, can move data, can interact data in a way where it is value-based, that it is based on a contract, not on a fee schedule. And so our biggest difference here is to tackle the main problem, the core problem of how do we transform the industry out of a fee-for-service transaction into enabling this value-based care model, which then ultimately allows all of these other innovations and changes to flourish at a level that is not being experienced today.
Thank you. Okay, next question. What is the biggest difference you see to making value-based care adoption a reality?
So I think this is in follow-up to what I was just mentioning. One of the most important items around once you move out of a fee-for-service world and you truly can start to process transactions in a value-based world dynamic, you then enable the provider, payer, patient, other third-party organizations to actually interact in a value-based way. If you look at the majority of value-based dynamics today, they're all retrospective, in arrears, some level of some capitated budget, global budget items, upside only. There's no real downside risk. And those dynamics and challenges are born out of, because we're in a fee-for-service environment, and that fee-for-service environment is, driving the interactions of data, you have providers that say they're willing to take risk, and ultimately, as being willing to take risk, they're not getting data appropriately. They're not getting data timely. And so when you change at its core and you move out of this fee-for-service world, you get the dynamics of unlocking the system.
Speaking of changing the core, the next question is, how does changing the core of healthcare enable value-based care?
Absolutely. So, it's kind of the example I gave when we were chatting earlier about moving the industry, in the financial services sector, from checks and cash to credit card payments and those types of things. It's no different in healthcare, right? When you live in a fee-for-service environment, you're limiting the interactions and the capabilities that those individuals have. And so therefore, you enable value-based would be no different than enabling the value points of mobile payments in the future, right? And so if you look at what credit cards did in the healthcare and the financial services system, is it unlocked a whole new world of capabilities. We feel that changing at its core, moving away from fee-for-service, will allow the industry to truly move to value-based, which then allows you to have risk-taking, risk-sharing, publishing price transparency for patients who know how much something costs when they go in to have the service. And as I mentioned earlier, out of the airplane analogy of getting all these crazy bills on the back end and actually knowing when you go to consume healthcare what the cost is.
Right. Yeah. Thank you. Okay. Next question. One of the challenges in healthcare can be patients possessing the needed community health knowledge to navigate the system. So, for example, topics like where to go for care, ED versus UC versus PCP. Can you speak on that?
Yeah. So, I think there's a whole dynamic of, how do you engage patients and how do you engage the consumer in these dynamics, right? And so, the main focus is if I can get the right information to any of the stakeholders in the system at any given point in time, then decision-making moves faster, driving the better proper use of care, moving towards prospective interactions, upfront interactions, drives a significant amount of changes. So when you go back to, the example I was sharing earlier, this airplane example, you have a patient who walks in the doctor's office, they need surgery, they are either impacted by social determinants, meaning, just their surroundings. Maybe they don't have access to certain levels of care. Those dynamics then force them into a decision-making process and decision-making path, which is kind of already defined for them. When you change the industry out of a fee-for-service, by and large, retrospective in nature view of the world, now you start getting more prospective manners of interacting in the industry, more prospective payment, more prospective pricing, more prospective price transparency. You start to be able to process that data faster, decisions move faster. Physicians that are in upside downside quality programs are able to make care decisions and move patients faster. And then quite frankly, then the access to healthcare with things like telehealth and solving social determinants, those things now become value add because they're not riding on historical claims infrastructure. They're actually moving in a value-based dynamic. So again, all of those things are things that the industry is trying to tackle today, but the limitations of how it's consumed and paid for are actually limiting the value of interacting with those organizations.
Right. Okay. Thank you for that. Okay. Now we're doing rapid fire, but you're ready for the next one? Can you speak on what makes your ecosystem different? Is it technology, consulting?
Yeah. So I think the biggest difference is, number one, the ecosystem is meeting stakeholders where they are today, right? Healthcare is different. Healthcare is an organization or an industry that has, as I mentioned earlier, adopted slowly or moved slowly. Quite frankly, it's moved slowly because of barriers in interoperability and challenges in terms of the dynamics of how healthcare works. I've been in my career a long time. I mentioned it earlier. The fact of the matter is that if you're forcing healthcare changes to make massive changes, organizations make massive changes, they don't, right? They have the tendency to adopt technology and retrofit it to, quite frankly, what they've been doing before, right? And so the key is understanding where organizations are. And when you understand where organizations are, then the path to get them to where they want to go. And it doesn't always have to be massive rocket science, right? So it's a combination of technology, it's a combination of consulting, but quite frankly, it's a combination of implementation of capabilities and then scaling those capabilities.
That makes sense. Okay, next question. There are major issues with healthcare disparities. Are these disparities addressed in your value-based care approach model?
Yeah, so I think there's a number of dynamics and disparities that are in healthcare today. Obviously, the biggest challenge is that there's social determinants of health, right? There's different inequities in healthcare, and those are not specifically items that we're trying to tackle. We are hopefully enabling the industry to actually make the changes that enable other organizations to, in this ecosystem, solve those disparity and equity problems, right? And so, I go back to, as I mentioned earlier, when you have a dynamic where you're asking a patient to walk into a doctor's office, receive care, they have no clue what it's going to cost them, they have no clue where they're going to have the service potentially, they really don't understand what the downstream interactions are going to be until after they've had that service. All of that is born on the fact that we live in a fee-for-service infrastructure, right? It's a service for a price, a service for a price. And so when you can actually sit down with a patient and say, okay, you're part of an ecosystem where when you get a knee replacement, it's a prospective episode. The provider is on the hook for being a risk-bearing entity. The payer and provider have agreed on a model that is going to drive value for you for a patient. And you know what? Your price is X. And you know that before you drive the rest of the episode. Now the abilities to provide equity into that or disparities into that or drive that patient in different dynamics, everybody's incented and aligned to get the right outcome.
Yes, thank you. Okay, next question. how do we address the biggest barrier to interoperability and miscommunications from data? For example, too many EMRs in our healthcare system, and the fact that there is no real gold standard of an EMR.
Yeah. So, I think, just putting down where the goats can eat it. This is part of the inertia of healthcare, right? I mean, how many times we have EMRs? Organizations have spent tons on health information systems and EMRs, and you still walk in the doctor's office and all the charts are sitting there in the back, right? And so that's the example of the inertia that exists. The fundamental fact is, though, that there's two types of interoperability problems. There is the interoperability problems of the patient chart and the EMR data and the information about the electronic medical record about the patient. Then there's the interactions that we live in a claims fee-for-service infrastructure, and all the interactions about how it's consumed and paid for run over EDI legacy rails that are completely fee-for-service. And so in our mind, tackling step one is to change how that's consumed and paid for, i.e. the claims interaction, the payer-provider interaction of how I'm going to pay for this service, is step one. Step two is, okay, once I've figured that out and I've got a prospective bundle, prospective knee replacement, there's a defined price. Now it becomes to, okay, how do I share the medical clinical data that goes along with those rails versus I'm sharing each individual little service that was provided. And so those are two different dynamics. We're not trying to solve for every one of them, but we feel like the first step is, if I get out of this model of interaction for price and I move to a series of episode-based interactions for a specific price, then now we're aligned on, okay, let's share a lot of clinical data back and forth or utilization data that is driving towards the outcome, but not the specific price of that procedure or volume or interaction.
Got it. Thank you. Okay. Another question. Where do you envision the spend being removed or reduced? Is it specialists and facilities? Most value-based models are PCP-centric. Is this what you are talking about, or something different? Or?
Yeah. So, I think it's McKinsey who put out a white paper about 2 years ago that stated that, about 75% of all healthcare reimbursement could be placed into episodes. And if you look at value-based care, the overwhelming majority of value-based programs out there today are some type of cap, some type of global budget or kind of global risk dynamic. And those are okay. The dynamic, though, is the challenge is those are kind of like half blown up balloons. You squeeze them in one area, they're bigger in another. And they're kind of a little bit amorphous. We truly feel that the area to start is specialty care. And specialty care specific around episodes. So ortho, spine, cardiac, maternity, those capabilities that are defined timeline infrastructures, they're defined timeline episodes that ultimately you can impact interactions and impact costs in a defined time frame and get an outcome. Now, you're taking costs out of this, right? But it's more around aligning the care required and aligning the outcome to actually thinking about just taking out costs, right? And so ultimately what you're looking to do is you're looking to align quality and risk. You're looking to take costs out of the system by improving quality, but then you're also looking at taking costs out of the system by directing that patient where they need to go, where they're going to get the best care that's aligned for their outcome, right? And so, it's kind of like risk adjusting the price and the patient where they go. So the 55-year-old marathon runner that wore out their knees running marathons that needs knee replacement, who has perfect body fat, no AMI, no hypertension, great blood pressure, probably can go to an ASC setting and have a rate for a knee replacement. The 55-year-old couch potato with, BMI, high BMI, high AMI, hypertension, big blood pressure issues probably needs a facility setting and an appropriate price, right? And so you're aligning how this is delivered they're all still in the episode structure. They're all taking risks. And ultimately, that's where our value comes in to help align, drive those programs. But in order to accomplish that value, you have to be out of a fee-for-service infrastructure. And that's why an example of fixing at the core is so important.
Right. Thank you. Okay. Another question. To accomplish these changes you were discussing, are you working with TPAs, carriers, contracts, employers, providers?
Yeah. So we are working with a set of stakeholders. The set of stakeholders that we work with are, insurance companies, payers, provider entities, health systems. We've worked some with employers as well as TPA. It's about in a market or region, healthcare is regional, right? So it's about marketing and working in healthcare in a region where you can build payer-provider partnerships that ultimately get to the outcome you're looking for. The dynamic with the employer model, and we've done some work with employers, is you need to be a really large employer to get ultimately a lot of volume, right? And so if you're a 10,000 employee company, how many knee replacements are you having? Not many. But if you're a 4 million covered live payer, you're going to see enough volume where those providers start to get an aligned strategy. So we worked with health systems on direct to employer contracts. We've worked with payers. It's ultimately about that alignment about how do you get connected in the ecosystem and drive value.
Right. Got it. Okay. Next question. How do you help clients define success over an 18 to 24 month period related to clinical operations, financial operations, et cetera? Do you have clinical, operational, and financial efficiency metrics?
Sure. So one of the secret sauce about how we look at the industry is you need the capabilities of putting your history into this lens. So one of the biggest things that we drive in the industry is taking a design of a program and then taking historical data and running it through that program. And then, ultimately being able to give the stakeholder, look, if you've been doing this for the past 2 years, this is what it would look like. A lot of organizations don't have that capability. And so then you start to drive metrics, you start to drive targets, you start to drive, the efficiencies. We are not trying to build our own clinical models. What we're trying to do is really be rails and technology that are enabling payer-provider partnerships to basically make the decisions they want to take, right? So whether it's using a payer's risk adjustment model or utilizing a payer's model or those types of things, those are capabilities that we bring to the table and allow them to ride on those rails. So, those are just dynamics. Again, meeting organizations where they are, meeting organizations where they are is critical to get them to buy in and get their adoption. We've seen most of what we do are episodes, ultimately driving prospective episodes. And in driving prospective episodes, there's always a movement there, right? So sometimes they start retrospective, sometimes they go to upside only, and then they move to full prospective. So it's really aligning incentives, payer-provider partnership dynamics.
Got it. Okay, we got a good follow-up question from someone else. Is this a reference-based pricing model?
No. So we are not, basically, building what the industry would, consider a reference-based pricing model, right? So what we are doing is we are supporting payer-provider organizations to individually contract and basically off a fee-for-service pricing model, build a true prospective episode model that drives incentives and value for both parties, right? And so, we aren't necessarily basing it on Medicare or basing it on some other dynamic. We ultimately build individual programs for our payer provider entities or our health system entities to design, this is the outcome I'm looking for, this is the quality and cost I'm trying to hit, and this is driving, importance for the patient and an outcome for the patient, right? And so, most of the programs are different. and have a nuance by, the market, because healthcare, as I mentioned, is local, and then the payer-provider relationship.
Gotcha. Thank you. Another question for you. How does quality improvement drive cost containment?
So quality is a big item, right? Quality is one of those things where I think the industry, quite frankly, is at the beginning of understanding the quality dynamic, right? And so in the episode world, there's a lot of methodologies that are utilized that leverage potentially avoidable complications. The Prometheus logic, for example, in episodes has this concept of potentially avoidable complications. Those are proxies for quality. And so, in a specialist, for example, bundle space, the dynamic is, okay, how do I avoid bad outcomes, and drive down utilization or costs from bad outcomes, right? And that's just scratching the surface on kind of avoidance of cost and quality. Where the industry really needs to go is, patient-reported outcomes, driving clinical standards around episode programs and, engaging that, how many days back to work is the patient supposed to be back to work after cardiac procedure? Did they make it early? Did they make it late? What's the pain level for a patient? And how do you get those into either the payer provider, organization and leverage those patient-reported outcomes, into the pricing model? So, with taking risk. And that also gets into some of the future of the social determinants, equity. How do you develop quality metrics and equity and all those? So today we're really looking at, for procedures themselves, is the outcome a solid outcome based on the experience and quality clinically? Didn't have complications, and then that reduces cost.
Got it. Thank you. Okay. Next question. Kind of a longer one. The one-off tracking of episodes of care bundles has been a struggle for both providers and payers. Are you basically automating that so it just works by running it through the machine versus manual work and the whole payer-provider reconciliation mess of exclusions?
So, not sure who wrote the question, but great question. I think this is the crux of the difference, right? And so the reason that a lot of the episode models have broken down has been that the connection point between the organizations, i.e. provider entity and payer entity, are still fee-for-service rails. What we did was we came up with a platform that hooks in our ecosystem to allow those transactions to still run over those rails. But when they're processed, they don't process fee-for-service. Right. And so they're automated to kind of, in our brains, basically move away from a service to fee schedule to service to contract. And so that automation, is happening with our ecosystem. And ultimately that automation then drives a lot of the downstream components that can happen with price transparency, financial reporting, provider reporting, some of the reporting we do, some reporting the payers are now able to do. It's a very flexible model. But at the end of the day, the automation is happening, taking out of fee-for-service into value-based contract. And once you have that, then you have the rails to be able to enable downstream capabilities, which drive further automation and capabilities from that perspective.
Okay, next question. How does this episode-based model transfer over to post-acute care like skilled nursing facilities and long-term inpatient rehab?
Yeah. So, great question. Most of the payers we've worked with have seen a pretty significant decrease in use of skilled nursing facilities and long-term inpatient rehab, mainly because when the episodes are structured at the beginning, and ultimately they are based on targets or prospective payment, you are aligning the outcome with the payment itself, right? And so, are there still needs for, some of these settings of post-acute care? Absolutely. But, when you align incentives to pay prospective and you align incentives to pay the risk-bearing entity, which normally is a specialist, more of the dollars for manage the episode home the risk, they are more incented to select that care pathway better, that then ultimately drives the value statements of reducing that cost. And so it's not just send this person to skilled nursing. It's okay, what's the best location for this patient? I could be on the hook for it if it's not included in my episode price, and so I better get more focused on driving the best location for these organizations. And quite frankly, specialists are great. Most of these specialists, they know exactly how to manage their patients. They know what they need to do with the patients and how to get the best outcomes. And when you align incentives of those dollars with risk, they can be well-oiled machines on getting great outcomes for their patients.
Gotcha. All right, so we get time for one more question, home stretch.
All right, here we go.
How is the influence of CMS value-based care requirements affecting the industry's adoption?
So, this is, I think, one of the big push and pull dynamics that, exists in the industry. Without a doubt, the CMS drivers of BPCI and the BPCIA model and the dynamics and initiatives coming out of CMMI, those are setting a path and a tone for the industry, and they play a key role in driving industry adoption. I think that the recent administration has doubled down on some of those and looking towards mandating some of these programs, and I think that will continue to help pave the way in expanding CMS and Medicare, Medicaid's interactions with that. I think the bigger impact has been the move to like Medicare Advantage and privatizing some of these programs and taking and bringing to the table commercial payer organizations that are interacting with Medicare membership that now are forcing to get more into this value-based model, right? As I go back to what I mentioned earlier, it's unsustainable the way it's going today. The costs keep going up. And so I think what COVID showed us is it's time for the industry to truly change. It's time for the industry to take some steps, changing at its core and driving these changes that we're talking about. They'll redefine the industry. The innovation that can be enabled by moving off fee-for-service rails and truly moving to value, it might bring up new models. It could pervasively help the industry adopt episodes, for example, and other value-based programs. And who knows, what that enables CMS to take with future innovation to help drive more dynamics, because now the commercial side of the equation is plugged in and it is kind of rowing in the same direction, if that makes sense.
Got it.
That is all the time we have for today. Thank you to Bill Nordmark for an excellent session, and to Enlace Health for presenting today's new masterclass with Becker's Healthcare. To learn more about the content presented, please check out the resources section on your webinar console and fill out the post-webinar survey. Thank you again for joining us today, and we hope you have a wonderful afternoon.